everyone, and thank you for joining today's webinar. Today we have scheduled webinar on the therapeutic relationship in clinical exercise physiology practice, which has been organized by Applied Science and Humanities Department of Parul Polytechnic Institute, Parul University. The main agenda of this webinar is to explain the cultural style of working with clients or patients in exercise physiology practice in Australia and the importance of the therapeutic relationship within this. While the webinar examples relate to her own field of practice, exercise, physiology, it is also applicable to physiotherapy as well as other allied health practices in all culture. I, Vaishali Nathwani, would like to introduce today's guest speaker, Gina Mendoza. She is a clinical exercise physiologist and exercise scientist accredited with exercise and sports science from Australia. She is also a dance practitioner and sports neurologist who has specialized in movement techniques. She has worked with elite level athletes at the Victorian Institute of Sports. Her work with athletes was presented at the Australian Innovations Festival. She has worked at Victoria University as a lecturer in clinical exercise studies. Her postgraduate research was specifically on the therapeutic relationship in clinical exercise studies. She is a published author and is a regular guest speaker on the Expert Channel TV. Currently, she is working in her own private clinic practice as a clinical exercise psychologist, working with clients suffering from chronic disease, chronic pain, and mental health issues. It's a privilege to welcome you, ma'am, here.
Thank you, Rayshali. Thank you very much for that lovely introduction. And yes, as Rayshali said, I'm Gina Mendoza. I'm very honoured to be here. I'm a clinical exercise physiologist, as Rayshali said, and I was formerly a lecturer in clinical exercise studies at Victoria University in Melbourne, Australia. And I was fortunate to do that because a lot of my talk has to do with that. And my PhD research was on the therapeutic relationship in clinical exercise physiology practice. So, hence the topic of my discussion, and the particular focus of this discussion is more inspired by the fact that I had the privilege of working with a lot of international students when I was working at the university. And so from that, I gained a lot of insight into how the therapeutic relationship may be interpreted in different cultural contexts. And as Rayshali said, I'm an exercise physiologist, so I'm speaking with you about this from the perspective of an exercise physiologist, but this can really apply to all our allied health practices, as you will hear as we continue. So, what is the therapeutic relationship? The therapeutic relationship, or the working relationship, or the working alliance, there are different ways of perhaps describing it, but fundamentally, the therapeutic relationship was conceptualized by Carl Rogers. He was a psychologist and he pioneered the therapeutic relationship, which is a client-centered approach in psychotherapy. And so the therapeutic relationship adopts a humanistic view. And it was from Carl Rogers' work that he developed the client-centered model, the client-centered approach more that he developed in the 1940s. And then in 1959, he created the model for the therapeutic relationship. So, the qualities of the therapeutic relationship. This is the really important part. The qualities of the therapeutic relationship are, number one, congruence. Now, what this means, now that says number 4, that slide says number 4, but that's just where we're up to. But this is number 1 for the therapeutic relationship, although The three qualities I'm going to say are all equally important. But the number one we're talking about is congruence. And that means that's bringing in the trust, the genuine qualities of the practitioner. The client or the patient or the participant, however they're described, needs to feel that they can trust the practitioner, that the practitioner is genuine, you know? And so that congruence, that feeling, that trust, that genuineness of the practitioner is very important in the therapeutic relationship. And another one of the main qualities of the therapeutic relationship is unconditional positive regard. This is really to do with having no judgment, zero judgment, so that when a client comes to a practitioner, they're not going to there to feel like they're judged, you know? They're there to feel supported. And that doesn't mean that the practitioner is going to agree with everything that the person's doing. Not at all. It means that the practitioner is there to be on the client's side, to support them and to help them to move forward without judgment. So it's like, I'm on your team 100% with zero judgment, because it's not about the personal views of the practitioner. I mean, they will have their personal views. We all have our own personal views, but we're not there to impose our personal views in the session with the client. We're there to support the client in moving forward. So there's unconditional positive regard. That's what that means. Okay, and the third main quality is, of course, empathy. Empathy and care, creating an environment that's caring and warm and nurturing and safe, so that the client feels safe when they come to see the practitioner. So these three qualities that I've just talked about, congruence, unconditional positive regard, and empathy, they're the three main pillars of the therapeutic relationship. Now, where does the therapeutic relationship exist? In all kinds of places, really. It could exist, I'll give you a more obscure, yet it's not really obscure anymore, example. It could exist with a hairdresser. You know, you think about it. You think about the close proximity of a hairdresser working with a client. And, you know, with a client who comes to see them regularly to get their hair cut, you'd be surprised how much a hairdresser needs to take on board when they're working with a client, when the client's getting their hair done. I mean, it's that close connection that I guess it's the closeness of the relationship that brings that therapeutic relationship into play. I mean, some hairdressers talk about sort of almost having to be a psychologist because they're listening to their client talking about their problems. So that's the context I'm talking about. They're not really a psychologist, but it's that therapeutic relationship that develops. So it can happen in all forms of healthcare as well, and which it should do. If it's a good working relationship, there should be a therapeutic relationship. If it's an ongoing treatment, that is. It obviously wouldn't be something that would be easy to develop in one session. But over time, that connection, that therapeutic connection would develop. Now, so the next thing we come to is boundaries. Now, there are boundaries with the therapeutic relationship, professional boundaries, because it's not about making friends with the person and even being friends with them on a personal level so that the boundaries get blurred. It's not that kind of a relationship. And there's no clear, and you know, we don't want it to be that there's no clear distinction between being a friend or being a client. You know, it's not that. So a practitioner using the therapeutic relationship needs to be skilled in doing so needs to be aware of themselves. And so when we look at the therapeutic relationship and we look at boundaries, well, that means that the practitioner really needs to understand themselves, know thyself, So they're not going to be projecting their own stuff onto the client, so to speak. We've all got our own stuff, but we're not there to put that on the client. So that's boundaries, professional boundaries in the therapeutic relationship. So, an easy way to perhaps understand that is that we all have got our likes and our dislikes, our personal likes and dislikes. And, some people, for just about all of us, some people will just instantly we'll just like that person for no particular reason. And we might not be aware of why, but we just instantly like that person. And so that means that everything's easier with that person, It's just easier just because we like them. And then there'll be some people that we instantly just think, oh, I don't know about that person. I don't really like that person. And for some reason, they just jar on us. And we don't really know why. Now, it's important for us as practitioners to remember that our triggers of our personal likes or dislikes, it's not about the client. This is about us. It's coming from us. So this has to do with us. This has to do with our own likes and dislikes and our own triggers. And when we're not aware of that, we may unconsciously start treating a person differently when they irritate us, and for a reason we're not even aware of. And do you know what I mean? When we might do that, and we don't know why, they just irritate us. So that's why when we're working with clients in a therapeutic relationship, it's really important to know ourselves. And this is why in psychology, and although I'm not a psychologist, the therapeutic relationship, although it's come from psychology, it's not any longer exclusive to psychology. It's used across all forms of healthcare. But in psychology, well, in Australia anyway, they have to spend a training psychologist has to spend about 6 months going to see a psychotherapist themselves so that they learn about themselves. They learn about their own patterns of behavior and what their triggers are. Their triggers might be and how they might respond in certain situations. So they learn to become more self-aware so that when they're in their sessions with their clients, they're not going to bring their own triggers into the session with them. So the therapeutic relationship, it's not just about, oh, okay, I'm going to be really nice. So everything's going to be fine. Yes, that's a really good place to start, but it's not quite as simple as that. It requires a lot of self-awareness to do it really well, a lot of self-awareness and understanding, which requires working on ourselves, So now, the very interesting thing about the therapeutic relationship is that they have found across all modalities of healthcare, and they've done a huge amount of research on it. They really have. So it has been found without question that if you have a good therapeutic relationship with your client or your patient or your participants, however you describe them, but health outcomes will generally be good if you have a good therapeutic relationship. If you have a poor therapeutic relationship, on the other hand, if you have a poor therapeutic relationship with your client, for whatever reason, Outcomes will also tend to coincide with that because they will tend to be poor. So, and based upon, this confirmed data that we have got, this an enormous amount of data we've got on the therapeutic relationship, we know that it's the single biggest predictor of health outcomes that there is. That's really interesting, isn't it? So it plays a very important role. I mean, that's really interesting. And that the therapeutic relationship of itself is the biggest predictor of health outcomes. So it's kind of important, isn't it? In fact, it's very important. Now, let us move to the therapeutic relationship and how we might, in our own culture, perceive the client-practitioner relationship. Now, I know that in Australia, we've moved towards a client-centered therapeutic approach, a client-centered treatment. And by that, the general understanding is that the client has a voice. The patient has a voice in their own healthcare. So we've shifted away from the way we used to once do things, which was the doctor was like the God, and everything the doctor said was everything you had to believe. I mean, it really was like that, and it's still like that for some people. You would never question that. But things have slightly changed, and probably significantly changed from that position. And so now we've moved into a more client-centered approach where the client gets to ask more questions. Because in the olden days, in Australia anyway, it used to be the situation where the doctor might not want you to be asking questions. This is not all doctors, but this was just something that commonly happened. You might ask a question, start out asking questions, and the doctor might say, no, you don't need to worry about that. Let me worry about that. Let me take care of that. I'll manage that. And that was often the way of doing things. Now, a lot of people preferred that anyway. Some people may even still prefer that. In fact, I'm sure there are many people who would just prefer that their doctor takes control. They don't need to worry about it. They might prefer that. They don't even know. But in a client-centered approach to healthcare, the client has a voice, and they get to have some input into how things go for their healthcare. So now, the interesting thing about this, I'm talking about Australia. I'm talking about the therapeutic relationship that was designed by Carl Rogers, and he was a Western practitioner. So it's important to note that too. So, how we may vary in terms of a different cultural approach to say, well, let me look at Indigenous Australians, to take that example. When I say Indigenous Australians, I should say Aboriginal Australians, because Indigenous can mean a broader range of Indigenous peoples, can't it? So Australian Aboriginal people, well, there is a different approach. There's a different cultural approach, a different therapeutic approach when we're working with Aboriginal people. And that is that we're going to be really mindful about not telling people what we think should happen. Not telling people what we think should happen as the first gateway into the process. We're going to be very respectful and ask. So it alters the balance slightly, knowing this, that being culturally respectful, we ask first. We don't decide first and then ask. We ask first. We're respectful in that way. And that's really important culturally for Aboriginal people. And that's a cultural understanding, and it's a respect for that particular culture, because it's not going to help a therapeutic relationship if we're not mindful of the cultural understanding of the person we're speaking with, will it? So it's all very well to say we need to have these qualities, these therapeutic qualities that I talked about. You know, the congruence, unconditional positive regard, and empathy, and then off we go and everything's going to be okay. No, there's a bit more to it. And that more to it is the person we're speaking with. Now, I said that I was very fortunate to have the privilege to work with international students when I was working at Victoria University. At that particular time, I had a lot to do with students who came primarily from India. Yes, India. And I loved that I got to work with the students from India. I really loved the students who came to our course. I genuinely did, who came from India, because I learned so much from them and they were lovely. Excuse me. Most of them had already completed their physiotherapy training in India. So they came to study in Australia already with a lot of knowledge. There were different circumstances. I mean, just as to mention this as an aside, there were different circumstances for these students because many of them had to work. I mean, very hard. They had to work at night, or they had to go straight from their studies into their classes, because most of the evening classes in the master's degree, which they were doing, were in the evening. You know, so many of them would go straight from being in their master's studies straight to working all night. So it was really exhausting. That wasn't fair. I was always not happy about that part. Not that I could change that. However, what transpired working with these beautiful people was that I learned a lot of cultural differences. I really did. Now, the first time I noticed this was when we were doing our practical examinations. And I was examining actually, yes. And so I had some students who were doing their practical assessment in a simulated example of working with a client, you know, acting. One was playing the role of the practitioner, one was playing the role of the client, you know, playing the roles of the exercise physiologist and the role of the patient or the client. So the student who was playing the role of, so the student who was playing the role of the patient or the client was given a condition, like a health condition, that they were to come in to see their student exercise physiologist about for treatment. And so in the simulated context, off they went, and the student practitioner had to deliver how they would approach dealing with treating this patient. Now, what really stood out was that all the student practitioners did a really great job. They really did. All the students had learned their work really well. But the one thing that wasn't quite right was to do with a cultural difference in understanding. And this is where it became really interesting to me. And so the student practitioner, I saw them again and again, would say to the client, now, what you need to do is this, and you must do this now. I want you to do that. And this is what you have that is wrong, that we need to work on. And this is what you must do. And they were being very confident and caring and taking responsibility. And can you hear what I'm saying? From what I've just described, can you hear what I'm saying? And now I've explained it to you by I gave you a clue. I gave you a bit of a clue when I talked about the Australian Aboriginals and working with that client group. and it requires even more sensitivity than usual in asking first. It was an example about cultural differences in the way we approach things. And so, can you hear from my description above that the approach was very much from the practitioner taking the lead and the client listening only to the practitioner and doing what the learned practitioner prescribed for them? Now, there's nothing wrong with this, except that when we're using the client-centered approach, this doesn't quite match in our culture any longer, not in Australian culture anyway. Now, I'm not sure about any changes that may have taken place in India in more recent times. I'm sure this forum can enlighten me on that. And I'd be very interested to know about that. I really would. If things have shifted from what they were, and this experience I had was about five or 6 years ago when I experienced this with the Indian master's students who were studying in the master's degree at Victoria University. So that was something I then spoke with the students about, and I spoke with them and everybody understood. But it was such a good learning example. But you know what? It goes even a bit deeper than that, I think. This is the thing that I also observed. And I would like your insights on this. So when we're talking about a cultural understanding, it's not just as simple as saying, all right, so we need to just shift the emphasis so that you're not coming across as you're the only one in charge. It goes a bit deeper than that. And this is something, again, I learned from the Indian students. Thank you, Indian students. I learned a lot from you. And this was when Indian students were submitting their assignments. And there was a bit of an uproar at one point because the assignments submitted had sections of text that had been taken from textbooks and put directly into the assignments. And the Australian lecturers were saying, no, you can't do that. You're not allowed to do that. Well, I talked with the students and I discovered that it's so disrespectful in Indian culture. It's so disrespectful not to quote the learned authors' words exactly as they are. You know, why would you destroy that and try to redescribe it? That would just be so disrespectful. And so we had no understanding of that in Australian culture. We had zero understanding. So we automatically in our culture, we're thinking, well, we're right. No. So we automatically, thought that. But no, we were saying, no, you can't do that. And people had not stopped to think, well, why is this happening? And so it was very interesting. It was an interesting thing to discover. And it's also a very difficult thing to alter, because when students are feeling like, well, this is the learned authors, these are their words, I'm not going to alter their words, that is so disrespectful. I mean, how do you say to these very culturally respectful students, no, you can't. You can't put their words in directly. You have to say this in your own words. How do you say this? And this comes down to respect, and respect for the authority of those words, and that kind of authority, it transcends, doesn't it, into the way a person practices. So I think there may be a connection between the authority of the written word and then that translating to the authority in a practitioner who has the learned education on the topic and how they're going to approach their work with their clients. I'm not really sure about this reflective analysis I'm presenting here in this moment. I've just presented this to you here. I'm sure that people in this webinar can enlighten me on this. I'd be really interested to know about your thoughts on that as well. So your comments are very welcome. But this is a very interesting topic, the therapeutic relationship, and the fact that when the therapeutic relationship is a good relationship, there is going to be a very strong likelihood of much better health outcomes than if the relationship is not good. And how this differs from culture to culture is something that is an interesting question to ask about. I know that in Australia, in terms of the client-centered approach that we've adopted a lot more, we have looked at the interprofessional approach. Right. Now, this is another interesting one, and it also is connected to the therapeutic relationship. So when we look at the client-centered approach, we look at the client in the center. If we imagine we have a wheel, and at the center of the wheel, right in the middle, we have the client. And then we have the sections, like we're cutting off pieces of a pie, like the spokes of a wheel, And we have sections of that relate to the interprofessional approach or the multidisciplinary approach. Now, I just said a word, multidisciplinary, that was different from interprofessional. Now, that in itself is quite interesting as well, because if you have a multidisciplinary approach, you might, for example, have a large health center or what they might call a super clinic, those huge clinics with a lot of different health practitioners working in the same practice. It's because it's providing multidisciplines for healthcare. All right. So that's multidisciplinary, and that can get confused with interprofessional. But there is a difference. Now, the difference is whether or not it's client-centered. See, it's finding its way back to the therapeutic relationship again. The key difference is whether the therapeutic relationship is going to be fundamental to that. So let's just unpack that for a bit. So say we have a person who goes to the doctor and they go to see the doctor at a clinic, all right, a big clinic, a super clinic that's got several general practitioners, GPs, some physiotherapists, some occupational therapists, what else? Some psychologists, some chiropractors, all kinds of practitioners, osteopaths, dietitians, all in this one big building. So the patient goes to see their doctor. And then the doctor says, okay, all right, you have weight problems. You are carrying too much weight on your body, and this is affecting your health. And this is why, in my opinion, you have developed type 2 diabetes. This is just an example. I'm just making up an example. And so the doctor says, I want you to go and see a dietitian. And so the patient then gets referred to see the dietitian. When the patient gets referred to the dietitian in this multidisciplinary clinic, the client discovers that his doctor has not spoken to the dietitian in this particular case. So he goes in there and the patient goes to see the dietitian and they have to start explaining everything all over again about themselves. So then the dietitian takes down notes and then the patient is told by the dietitian, you need to see an exercise physiologist to help you with exercise to help you lose weight. All right. So the patient then has to make an appointment at reception to see the exercise physiologist. When the patient gets to see the exercise physiologist, they go into the session and then they realize that neither the doctor nor the dietitian has spoken to the exercise physiologist. So the patient has to describe everything all over again. Thankfully, this has changed a lot in Australia. So we have something like a team care arrangement set up now where healthcare professionals are expected to communicate with one another. But that's not always the case. It's still not always the case, even with a team care arrangement, unfortunately. But can you see the frustration for the patient in that situation where they're already not feeling great? And that's why they went to the doctor in the first place. And they have to keep going from different health professional to health professional that they're getting referred to. And every time they have to start re-explaining everything all over again. Now, in an interprofessional approach, this is where there's a genuine team care approach to healthcare, where we may have a practice where we have, for example, let's see, say it's a clinic for people, exclusively a clinic for people who have type 2 diabetes. And there'll be some general practitioners, the GPs, there'll be the dietitians, the diabetic educators, the psychologists, exercise physiologists. There might be some osteopaths there. This is just an example of a list of people who might be in that health team. That would be a typical health team for type 2 diabetes anyway. And so now in this interprofessional context, it will be the practice manager. They'll probably be the one who's going to arrange a meeting, a team care meeting, so that everybody is on the same page, working with this particular client or patient. Or they have things set up in a way so that the notes are clearly communicated so that everybody understands what's going on for this particular client. So by the time they move from this practitioner to the next practitioner, the doctor has communicated with the dietitian, and the dietitian knows before the client walks in the door what's going on. And so it makes the client feel very, very nurtured, and part of a team care arrangement, and in that true sense of it. And the client feels valued then. And that's an interprofessional approach where the client really is at the center of the healthcare. Okay. And the other interesting thing about the interprofessional approach, I find all of this so interesting, actually. The other interesting thing about the interprofessional approach was that the World Health Organization started the ball rolling on this. And they started the wheels in motion on the interprofessional approach in 2009, 2010. And the reason that they did this was because in countries that didn't have very many resources, which obviously was not in the Western world, well, they were looking at ways to create healthcare and make healthcare more available for everyone. So the way they worked that healthcare was to create a team a team of supporters for that client, so that the client was at the center of the healthcare. So there might be a doctor, there might be a family member who was able to be a carer, and they might be able to become part of the healthcare team. There might be somebody who was a volunteer, somebody who was able to provide helpful resources that are going to help that person. And so out of less, that was the whole idea for it, when there weren't enough resources. So out of less, they were creating more for that person who needed the health care. So it was still putting the patient at the center of that wheel. It was very much doing that. Putting the patient at the center of the wheel with all the different spokes, which were all the people involved in being part of the healthcare team. But this is where the interprofessional approach actually originated. And that's why it was implemented in the very first place. And it's actually a really beautiful model, isn't it? When you think about it and why it was created, that original model, and trying to do that as a Western model, I mean, actually, to be honest, it's been quite problematic. That's so, and it's been problematic because when health practitioners in their own right, I'm talking really more about Western health practitioners here, and they're wanting to be their own boss, working in a bit of a silo by themselves and not having to bother with anybody else. And then that sort of situation is less conducive to having that interprofessional approach. So it has been problematic trying to implement an interprofessional approach more widely. But anyway, that's a description of a client-centered approach in an interprofessional context. And a client-centered approach is the basis of where Carl Rogers conceptualized the therapeutic relationship, where the therapeutic relationship is all about that working relationship with the client or the patient. It's not a matter of an unequal imbalance of power. I mean, there can't be an imbalance, really, because the practitioner has that power. They've got that expertise, and the client has gone to them for that reason. So there is that kind of an imbalance, but it's a matter of doing the relationship in a balanced way, where the client's not feeling disempowered because of the power that the practitioner has. And this is why the therapeutic relationship, although it's simple, it's also complex. It is complex, yet simple. Can you see that? It requires a lot of self-awareness and understanding coming from the practitioner, and really genuinely implementing those very important qualities, which, again, just to recap on those, are congruence, which is being genuine, because that's where we're going to be able to develop trust. Because if we're not genuine, you know what it's like dealing with fake people. It's very difficult to feel like you can trust them. So the practitioner really needs to be genuine. They need to be authentic. They need to be human, They need to be human. And as Carl Rogers conceptualized the therapeutic relationship, it's the humanistic approach. A humanistic approach contains empathy. So the genuine person and their approach is the practitioner who's going to imbue a trust in that working relationship. And that practitioner will have very clear boundaries because they will know themselves. They will know that what their own things are. They will know thyself, so to speak. We're all human. We all have our own likes and dislikes. We all have our own weaknesses. We all have our own strengths. But to really know ourselves requires developing self-awareness around that. So it's not just about us being authentic and genuine so that we're just going to pour everything out on our client. No. We're not going to do that. We're going to have very clear boundaries because this is about the client. It's not about us, is it? These sessions are not about us. They're about our clients. And then that unconditional positive regard. Just say a person's going to see a psychotherapist and this person has created enormous dramas in their life because of the way they're behaving in the interactions with other people. Excuse me. And that person goes to see the psychotherapist. Now, I'm not a psychotherapist. I'm just I'm not giving psychotherapy advice. I'm just giving you an example, just a little case example. And so the person goes to see the psychotherapist because they're so unhappy because all their relationships have failed and they just need some help with that. Their life is a disaster and they're angry. They're angry with everybody. And now it's the psychotherapist's job to care for that person. They might see this person and think, wow, it's no wonder. It's no wonder you're having a difficult time. Can you see what you're doing? Can you see how you're behaving? You're angry. You're even projecting that anger on me. It's not the psychotherapist's job. It's not the psychotherapist's job, that was hard to say, to come across as being judgmental of that client. It's their job to gently and safely help the client to understand what's happening and help them, empower them to shift them out of the way of doing things the way they're doing them and help them to move forward and make things easier for themselves. That's what their job is to do. And to do that, they need for the client to feel safe. They don't want the client to feel judged. Because remember, our personal views don't come into this. The client needs to feel that their practitioner is on their side and unconditionally there to support them, not to judge them. And so this is why there's a bit of a joke in psychotherapy or amongst people who go to see psychotherapists, that is. I'm their favorite client because they like to feel that they're their psychotherapist's favorite client, and that they feel that level of care. They like to feel like the favorite because they do get such a great level of care. It's the psychotherapist's job to make that client feel special, and it's so important that they do feel that in a way because that they do feel valued in their session. And that unconditional positive regard that comes from the practitioner is so important, not judging them. And so then, of course, which is not a final quality, it's such an important quality of the therapeutic relationship, it's empathy. A lot of practitioners might not necessarily be the most empathic people. It's true. They might not naturally be. So, we all know about that, I'm sure. Many of us will know we might have been to see a healthcare person and thought, oh, well, they didn't seem to have much empathy for me. Well, one of the qualities of the therapeutic relationship is empathy, caring. The client must know that we care and that they must feel safe with us. It's so important. And the environment we create for them really needs to be warm, so that they feel nurtured, they feel valued, they feel nurtured, they feel safe. And that comes from us them having an empathic person sitting with them in that therapeutic relationship. So it seems simple, doesn't it? And it is, as I said, but it does take skill. It takes experience and practice. But just knowing those things is a really good place to start. And knowing the cultural differences, being aware of that. So, we might have a client who comes in to see us because of cultural reasons. We might learn from speaking with them that they would prefer that we just play the authority role. We need to listen to that if that's the case. And that the way they wanted to do things is because of that's how they feel safe. So it's a matter of judging that for ourselves as practitioners, isn't it? It really is. I mean, I know in my culture there would not, be usually the case in these days. Most of the time, I would say that most clients will want to be heard. They will want to have a voice. They will. And it doesn't mean they're going to get to decide, oh, yes, well, no, I don't agree with you, doctor. I think if you're prescribing me those antibiotics, I think I would rather take these ones. No, it's not that kind of voice. I don't mean that at all. But it's that they're heard. It's that they have a voice and we hear them. And so, and also, the other part of the skill is in hearing them. There is a time limit on the consultation too. So it's managing that as well. And so, look, on that note, I think I will conclude this session, and I've really, really enjoyed being here with you. And, thank you for inviting me to present on this webinar. I really appreciate that. And I'm looking forward to your feedback and your questions if you have any. And I'm sure that will be enlightening and interesting, I'm sure. So thank you very much. Thank you.
Yes, thank you, ma'am.
Thank you.
Yes, it was very nice listening to you. And
Yes.
this session would surely help our students as well as faculty.
Okay.
Yes. And there is one or two questions. Hello.
Do I hear the questions or do I?
Yes, ma'am. Yes.
Oh,
I'm,
okay.
I'm letting you know the question. Um,
I hope I can
if
answer them.
someone, yes, if someone comes to you, ma'am.
It doesn't matter.
Okay.
I don't need to answer questions. I mean, that can be
Okay.
something that people think about afterwards. That's fine.
Uh, one of the question is, ma'am, that if someone comes to you and he thinks very negatively, right? Then how will you deal with him or her?
Well, the main thing is when I was describing about this being about the client, not us. It depends. Are they being very negative towards us? Is that what you mean? Maybe a bit aggressive towards us? We could have a boundary on that. If we have a person who comes to see us and they're being aggressive and their behavior is not appropriate, we have the right to say, I hear that you're probably not in a good place to be talking about this at this time. I would like you to come back to see me when you're feeling in a better place to come and talk about this calmly. because it's not our place to have to deal with somebody throwing a lot of anger on us either, is it? So that's how I would deal with that one. If it was somebody who was just very negative in their life and they were feeling very upset and nothing was working and nothing was going right, it would be our place to listen to that and make sure we hear what they're saying. Don't try and tell them how to feel. That's a very important one. We don't tell them how to feel. We offer some solutions of how we might try something to try and shift that into, let us look at this. What about we try this? Rather than saying, oh no, well, you shouldn't feel like this. You know, if you always feel negative, you're never going to get anywhere. We wouldn't want to approach it like that. Again, it's us to be there to support them into trying to shift. Now, we might want to look at the stages of change. You know, there's a change that a person needs to go through when they're going through their healthcare transition. And they might be at the very beginning. They might be in a place where they're not even ready to shift forward. So as a practitioner, we need to be aware of that as well and work with them where they're up to. So if they're not ready, we need to work with that. We need to be smart about it, caring, give them small steps, small manageable steps, something they can manage, something they're going to feel that they're going to succeed with. If we give them too much and they feel like they're going to fail or it's going to fail, we need to be a step ahead of them and think of that too. But as a general rule, it's a good idea not to give too much all at once anyway. So I hope that answers the question a bit. If it doesn't, let me know and I'll speak a bit more on it.
No, ma'am, it's perfectly fine. So I think here we end with the session, ma'am. If
Okay.
there are some other questions, then we will sure let you know.
Thank
So
you.
yes, and thank you so much, ma'am, for joining with us today and giving us your valuable time.
Thank
And
you. Thank you
we are
very much.
thankful to the head of our department, Mr. Hemal Patel, sir, and the HI, Dr. Jatin Vaidya, sir, as well as the president of our university, Dr. Devanshu Patel, sir, for motivating and supporting us continuously for conducting such webinars. Thank you so
Thank
much, ma'am. Bye.
you. Bye-bye. Patel, are you still there?
Yes, ma'am.
Oh, you're still there?
Okay. Yes, ma'am. You can leave the session. No issues.
Oh, yeah, I just wasn't sure. So was that okay? Was that okay for you?
Yes, ma'am. It was perfectly fine, and the session will surely help our faculties as well as students.
Oh, yes. Sorry, say that again.
It The session would surely help our students as well as faculties.
Oh, good, good. Thank
Yeah.
you. Thank you,
Yes.
Raishali. Thank
Yes.
you very much. All right. Well, I'll see
Bye.
you then.
Bye.
Bye-bye.
Bye.
Bye.